In this lesson, we'll continue our discussion of lower respiratory infections. We'll take a look at a big one, tuberculosis, and then histoplasmosis and anthrax. So let's start with tuberculosis. This is something that you definitely hear about frequently in public health news because it's something that it's just not going away. It's actually getting a little bit more difficult to treat. So this is a bacterial infection. It's caused by Mycobacterium tuberculosis, and it's basically transmitted by oral droplets from somebody that has an active infection. So again, somebody coughing and you're in close proximity, and it's something that we could definitely get. It occurs more frequently in people living in crowded conditions, people that are immunodeficient, right? This is a big problem of people that are HIV positive, people that have malnutrition, alcoholism during times of war, people that have chronic disease, and as I mentioned before, this HIV infection kind of goes along with the immunodeficiency. So let's take a look at the pathophysiology. Like I said, it's caused by Mycobacterium tuberculosis. This is a bacteria that's somewhat resistant to drying, and it's not destroyed by many disinfectants. And it can actually survive in dried sputum for weeks. So that's part of the problem. It's contagious. It is destroyed by ultraviolet light, heat, alcohol, glutaraldehyde, formaldehyde. And one of the things about it, as far as our defense mechanism, it doesn't initiate the normal neutrophil response. Remember, the neutrophils are one of the first white blood cells that will go attack bacteria. Instead, we get something known as a cell-mediated immunity. Remember, that's the type 4 type of hypersensitivity reaction, except that it's not a hypersensitivity. It's just a normal type 4 reaction where we have our T cells attacking the bacteria. Now, this primarily does affect the lungs, but it can be in other organs such as the kidney or the bone. We'll talk about that a little bit also. So we can break the pathophysiology down into two parts. There's a primary infection, if you want to highlight right over here. That's a couple of slides. And then there's going to be something known as the secondary infection or reinfection. So we're going to break it down that way. So let's start with the primary infection. This is when basically the organism first enters the lungs. Now, if the individual is healthy, right, they have a strong immune system, they end up having a cell mediated response, right? So if the cell mediated immunity, the response is adequate, the bacteria are going to be engulfed by macrophages, and there may be some local inflammation in the lung. Um, some of the bacilli, which are the Mycobacterium tuberculosis, migrate to our lymph nodes, and that initiates that type 4 hypersensitivity reaction where the T cells are going to try to take care of this problem for us. So the macrophages and the T lymphocytes cluster together, forming something known as a granuloma, right? So they'll go to the bacteria, they cluster around the bacteria, and develop something known as a granuloma. It's just a cluster of these white blood cells and the bacteria. Now, the granuloma still contains live bacteria. It's not that the macrophages and the T cells are getting rid of the bacteria. The bacteria are still there. They're just kind of trapped in the granuloma, and there is some destruction. There is something known as caseation necrosis. This is one of the types of necrosis that happens in the center of the tubercle. So we changed the name of the granuloma now to a tubercle. This is where the white blood cells and the bacteria are located, right? We call this a tubercle. And in a healthy person, these tubercles will actually calcify, and it's something that's visible on the chest x-ray. You can actually see the calcified tubercles on the radiograph. In radiology, they call those Gone complexes. Okay, so basically what we did, we had this granuloma. Let's go back to the previous slide. That's going to be the macrophages and the T lymphocytes clustering together, right, forming this granuloma. In the middle of the granuloma, we have the Mycobacterium bacilli. We now call that a tubercle. Within the tubercle, there is some destruction of the lung tissue. That is known as caseation necrosis, right? It's a type of necrosis. Kind of looks like a cheesy, cottage cheesy type of necrosis, hence the name. Um, if the individual has a good immune system, these tubercles will calcify, right? These lesions will calcify. They're visible on the radiograph, and then we call them Ghosn complexes. Again, that's a terminology that the radiology will use. Now, again, as long as somebody is healthy, right, they have a good immune system, the bacilli will remain viable in a dormant stage for years. So as long as the individual's immune system is up, right, they're going to be good to go. Um, the individual's resistance and immune responses, if they're high, the bacilli remain walled off. So when somebody has this primary infection, right, they have been exposed and infected. However, they don't have um, the active disease, right? They don't have active TB, and they're asymptomatic, right? They're really not showing any symptoms, and they don't transmit it, the disease, right? So when somebody's in primary infection, this is really an important slide, right? They're infected, but they don't have what they call active TB, and they're asymptomatic, and they're not contagious, right? They don't transmit the disease. So, secondary tuberculosis or reinfection, this can occur years and years after the primary infection. And this is where the bacteria in those tubercles are going to be reactivated, right? So it's kind of happening again, so to speak, hence the name secondary. This occurs when the patient or the client's cell mediated immunity is impaired, right? So if somebody's immune system goes down, stress, malnutrition, HIV. And again, even as we get older, our immune system may not be quite up to snuff. So what happens is the bacteria, the mycobacteria, begin to reproduce, right? And they're going to multiply, and they now start to infect the lung. And watch this, they begin to destroy the lung tissue at this point. They're going to start damaging the lung tissue, and now the disease is contagious. This is what we would call active TB, right? At this point, being in close contact with somebody with this form of TB is going to be contagious. So the tissue destruction that's happening, right, this is actually going to form large areas of necrosis. Here's a really important word, highlight this. We end up having something known as cavitation, right? This is the formation of large open areas in the lung with erosion of the bronchi, right, the tubes inside the lung, as well as the blood vessels. And this is what allows now the spread of the disease even to other parts of the body, right? So cavitation allows for the spread of this TB to other parts of the body. Bear with me one second. Yes, let's take a look at this real quick. So basically they're showing us some of the possibilities that can happen here. So let's say somebody inhales the Mycobacterium tuberculosis, goes into the lung, we get a inflammatory response, and we get a delayed hypersensitivity reaction. Again, that type 4 hypersensitivity reaction. That happened when the bacteria went to the lymph nodes. I didn't mention this either. I'm sure we've all had a TB test, even to come to college, where they put the PPD underneath your skin, right? They kind of give you a little bit of an injection. If you notice, they put the needle not straight in, they kind of put it down at an angle, and they inject it under the skin, and they're testing you for TB. That's because what they're seeing is if you have a delayed hypersensitivity reaction to the TB bacteria. So this is how we test. One of the ways we can test for TB. So anyway, the individual has the infection in the lung or the bacteria in the lung. If they have good resistance, right, they have a strong immune system, the tubercle is going to be formed, right? There'll be some caseation necrosis in there, but it all becomes calcified, and we see that on the X-ray. That's going to be known as the Ghosn complex. So hopefully somebody will stay like this the rest of their life, right? And they're going to be good to go, right? They're not symptomatic, right? They're not considered to be contagious at this point. Now, if their immune system goes down, let's say they have immune suppression, the organism then becomes reactivated. That's now going to be secondary or reinfection, and then we'll get the cavitation. The other way that we could get to cavitation is here. If the individual had the bacteria but didn't go this way because they had a good immune system, they just had low resistance, they can go right to active TB. And now they'll be contagious and they can spread to other organs. Okay, so let's just go back a minute, make sure we got everything on this slide. Yeah, this is an important slide too. Okay. So when TB spreads to other parts of the body, we call this miliary or extrapulmonary tuberculosis, right? This is a rapidly progressive form in which multiple granulomas disseminate into the blood, right? So now we have the TB into the bloodstream, right, spreading to other tissues such as bone and the kidneys. This is common in children under the age of 5 years old, and also in adults that are immunocompromised, right there, so their immune system is suppressed. And again, there's early dissemination to other tissues, meaning that once that cavitation happens, right, it can just easily spread to other tissues. If the lesions are not found in the lungs, but they're only found in these other organs, they consider this to be not contagious, right? It's not contagious. Right? But just know that miliary or extrapulmonary tuberculosis is the type of tuberculosis that does spread to other organs once those granulomas get into the bloodstream. Okay, so let's take a look at the clinical manifestations of TB, tuberculosis. So as we mentioned earlier, when somebody has primary tuberculosis, they are asymptomatic, right? They're not showing any signs or symptoms. They're not contagious. But when somebody has secondary tuberculosis, right, the reactivation, when they're active TB, they're going to have symptoms, right? So they'll have an insidious onset of symptoms. They'll have, and again, insidious onset just means a slow onset. They'll have anorexia, right? Not hungry, malaise, not feeling well, fatigue, weight loss. Night sweats is common. They'll have a cough that becomes severe with cavitation, and they'll actually spit up blood, or not spit up blood, I should say cough up blood, right? So they'll have a purulent sputum, meaning, right, pus in the sputum, right, from the infection with blood. So as far as the diagnosing it, they'll do that PPD test, right? That's the test again we've all had, especially just to come to college. You have to have it, where they'll test you for TB. But when somebody has the active TB, they'll do a sputum test, checks chest X-ray, right? And then when they have the sputum test, they'll actually culture the sputum and see what bacteria or what medications the sputum is sensitive to. Okay, so as far as the treatment of TB. This is something that you don't just get a prescription for a week and you're good to go. If you notice here, the treatment varies from 6 to 12 months, right? So we figure on average 9 months or so, right? And it's not just one medication; it's usually a cocktail. Effective treatment requires monitoring and following up, and it's expensive. So again, if you think about it, if you have somebody that's homeless has TB, or somebody living, during war times, trying to make sure that they're, following their treatment plan can be very, very difficult, right? So TB is becoming an increasingly serious problem because of, again, homelessness and crowding at shelters, HIV infection, right? That's a big population of people that have TB are people that are HIV positive, lack of health care, right? People aren't getting the adequate health care. And here's the big one, a lot of the TB strains are resistant to the cocktails, right? So it's a matter of finding new drugs that will get rid of the TB. Okay, so the next lower respiratory infection we want to take a look at is known as histoplasmosis. This is a fungal infection, right? It's common in the Midwestern part of the United States, and it's caused by Histoplasma capsulatum. And one of the problems is it's in the spores. The spores are released by the fungus, and we inhale them in different dust particles. So a big group that's affected by this are going to be people that are HIV positive or AIDS, right? Their immune system is suppressed, and this histoplasmosis becomes an opportunistic infection. Initially, it's asymptomatic, but the second stage, they're similar to TB. They'll form a granuloma, and there'll be necrosis, and they'll also have night sweats, fatigue and cough, and they're going to be treated with different antifungal agents. Right, so you may or may not hear about this one or treat patients with this one. Right, histoplasmosis. Again, it's a fungal infection, and the spores of that fungus are inhaled, and again, they're going to cause granulomas. The last lower respiratory infection we want to take a look at is anthrax. Right? You hear about this every once in a while because it can be used in wartime as a biological weapon. But sometimes you do hear about like livestock such as cattle having anthrax infections. So you may see it kind of in a public health kind of way, but you may also see it as a biological weapon way. So this is a bacterial infection. It's a gram-positive bacteria known as Bacillus anthracis. It affects the respiratory tract. That's why we're talking about it here. But it also can affect the skin and the GI tract. So let's kind of just take a look at the inhalation anthrax. Again, when it affects the respiratory tract, it will produce flu types of symptoms, even severe acute respiratory distress. The SARS, we had talked about that in a previous lesson, about 3 to 5 days after the exposure. The bacteria release toxins that can put the patient into shock, and one of the reasons they use it as a biological weapon, right, it is highly fatal, right, high fatality rates. So they're going to treat this, since it's a bacteria, with my antimicrobial agent. You can see ciprofloxacin, um, and they do have animal vaccines available. Again, like I said, this does occur in livestock, so that is a possibility if somebody were to be working in farming industry, that type of thing. Okay, so that concludes this lesson on our TB, histoplasmosis, and anthrax.